I've already grafted 5 and 29, and so that's what we're doing today. We're placing implants 5, 29, and we're going to torque test 4 and 26.
Go ahead.
So I have a question for you. This is Cale Levitt. If I'm trying, so I'm a general dentist, and let's say that I'm going to cut a crown on 30. What would be the best way to position that scope? As I've played around with my scope, I'm used to cutting that with direct vision with my loops. And as I put the scope there, of course, it kind of looks like it's inverted from what I'm used to seeing. But do you find it, do you need to use your mirror when you get to that aspect? Because I can usually do that direct because I contort my body. Is that something I just need to get used to and practice doing? Or do you have any tips or tricks to help with those awkward positions?
So I do find some areas overall just tougher to work with. I mean, everybody in the office knows if you give me 3 gum grafts in the lower right on the same day, like I'm going to go bonkers here. So it just, you know, some areas are tougher to work with, and the lower right is definitely it for anything, whether it's a scope or no scope. For that, I would definitely have the patient just turn all the way towards the left side, and with my left hand retract and get the scope onto that completely perpendicular position to the tooth. I find that would be the best way to do it. I think we're kind of trying to do it a little bit when I was placing that implant into 29 today. It was kind of similar to that. I think there's still going to be areas where you have to use a mirror, like the lingual of that area. You're probably still going to have to use a mirror, but you use a mirror through the scope. And I don't know if you can see some of that. You couldn't see my view of what I was doing on the scope, but John was able to see that. And he, you know, there are certain things that to him felt or seemed really neat, that you can look through the mirror and the microscope, and the vision is just incredible. So it's not really one or the other. It's using both to whatever suits you best.
And as you're
the question as well.
That did make sense, but one other follow-up question: as you're transitioning from let's call it direct vision through the scope to using your mirror, like that focal distance changes. Do you have your assistant just kind of go back and forth with that fine-tuned focus, or how do you manage that?
The biggest way to make the scope life easier with you is to get your assistant to buy on 100%. My assistants are typically in charge of the microscope. I want them looking at the scope so that they move and change the focus depending on what they can see. Because if they can't see, then I can't see. And there are times today where, you know, just because we got behind right at the beginning of the day, and so I was just kind of rushing through some positioning things. I wasn't letting my assistant do it. I took charge of the microscope myself, but ordinarily the assistant does 90% of that. And it's really, really, really key to have your assistant do that, so that they don't have, otherwise you're just constantly telling them, hey, scope, change the focus. Like you say it once or twice a day, it's no big deal. You say it literally 30,000 times a day, it'll drive you crazy. So your assistant has to be the one who's in charge of the scope, changing the focus, changing the position, and they can only do that if they're looking up at the screen also.
Do you have any accessory screens in your ops? So we could just kind of see one on the like one angle of your operatory. Do you have a screen behind you that you're looking at, or are they just looking at the main screen?
So I do have a computer behind me in the 12 o'clock position, and when I'm recording surgeries for video, that is showing on that 12 o'clock. And sometimes my assistant will look at that screen, and sometimes she won't. Sometimes they'll be looking up at the actual scope screen. It doesn't matter to me which one they're looking at, as long as they can see. But the one behind me is 2D, and the one in front is 3D. So I don't know, I think when they're looking at the screen, it's really 90% looking at the microscope. Sometimes when they're looking in the mouth, just because of suction, you can't see everything on the microscope. So they want to see what's going on in the back of the mouth. sometimes they will be having direct view looking into the screen, looking into the mouth. So they're kind of facing the 12 o'clock position, and see them looking up at the monitor just to get another look of what's happening up on the screen on the scope. So there has to be some real real intense ownership from your assistant. They can't be passive in the process.
There was one other question. Let's see. Please explain the different positions and different procedures for the assistant.
So the different positions for assistants, I like them. I'm kind of at the, 11 o'clock position. I might even be like 11:30-ish type of thing. And I like them being almost at the same angle, because if they're too far towards the 9 o'clock, they're going to look in the patient's mouth. If they're more in the, did I say 9 o'clock? I would have meant, what's the opposite there? 3 o'clock?
3.
Yeah. So I like them more in like the 1 o'clock, 1:30 maybe at most, so that they're still focused on looking up at the screen. And that would be the most natural fit for them.
And the more they're on looking at the screen, like looking directly at it, the better view they'll have than being like at a angle, at a 3 o'clock.
Yeah, no, I think if they're too far towards the side, then it's going to affect it, but not in that. You want to ask them?
No, at 1:30, it's great.
Assistant positioning. There was a question about what's easiest for you guys, what's best, what do you find is best?
Well, we have it on the screen behind the microscope, so behind Dr. Puterman.
Do you always have it?
Sometimes,
or only when we're recording?
No, sometimes I have it up there and I'll look.
There you go.
So I sometimes have it on the screen in front of me, but also sometimes I'm just looking in the mouth. But if I need to, then I'll look. I'll just look. I have a habit of having my knee by the patient's head, and that's better positioning for me personally. And then I'll look at the screen when I need to.
And you typically stay at like a 1 o'clock to a 2 o'clock.
What would you say? I mean, you saw how I was sitting.
Yeah, that's about right.
Yeah.
Okay, cool. Perfect. Thank you.
Mm-hmm.
What other questions, if any? So any last parting words, I guess, Dr. Puterman, for the group?
You guys have all bought the scope. You guys all own it and are having training on it, or?
Well, we got, let me see. We got 1, 2, 3. We got 4 owners and then 5 owners. Yeah. And then the other ones are their local reps.
Yeah. If you're getting used to it, the key is to really stick with it and use it on every procedure. I use it at every single procedure. That's why I got 2 of them, because I work out of 2 surgical rooms. I never wanted to have that thought process of, do I want the scope for this? Do I not want the scope for that? And so I got 2 of them, and it really has helped my immersion into it, being able to do it on every single procedure. It's always going to be a help. And there are cases like, asked about that number 30 crown prep. There are cases where it's not going to be 100% everything. Like if I'm doing an implant on 31, I know I'm not going to use the scope throughout that procedure, but I'm going to use it maybe 20-25% of the time, and that's okay. It's still better than not using it at all. So even when you think that you're not going to need it, or it's not going to be a benefit, or it's going to be challenging, trust me, set it up. There's always some part of it where you look at the scope, you're like, okay, I get a better view with the scope, and it's the only way you're going to get used to it 100%. I think, John Bruce was here, and he was obviously the only doctor here checking it out. And I think maybe if you had anything to say with what you found different looking at me using it versus what you were doing.
Yeah, I mean, honestly, I didn't see him not use it, but just from observation, his posture is really good. I bet his back hurts a lot less after using it. That's really the biggest thing that I took away, just from standing behind you and actually looking.
Yeah.
You weren't leaning on the chair or anything at all. You're sitting up straight.
Yeah.
So, I mean, from that perspective alone, I think it's worthwhile.
Yeah,
Cool.
your ergonomics looked awesome.
Yeah,
Everything
there were
looked
very few
great.
things in
So-
practice that have like changed everything for me, and this is one of them, seriously.
Thank you, Dr. Puterman.